Thank you very much, and many thanks to Eva and Bertrand for this kind invitation. So, with all the progress that we have seen over the last 15 years, there is a question which is coming again and again. What should be the treatment goal for multiple myeloma? Now that we have several regimens that can induce a complete response, we have to balance our aim to achieve the deepest possible response, complete response, which we know may be associated with better outcome, but also with the toxicity that these treatments may induce, and also with the comorbidities that patients with myeloma frequently have. As we know, myeloma is a disease of the elderly. Clearly, the incidence of myeloma is rising because of increase of the life expectancy. And in a similar manner than in younger patients with myeloma, we have data today to support that depth of response in the elderly non-transplant treated patients is associated with longer progression-free survival and better outcome. And now I would like to go through the different regimens that are approved for the treatment of elderly patients with myeloma who are not eligible for high-dose therapy. First of all, the first new agent that came into this picture was thalidomide, now almost 15 years ago. And there have been several trials which have evaluated the addition of thalidomide to melphalan prednisone, and a meta-analysis shown here showed that there is a modest improvement by adding thalidomide to melphalan. You improve PFS by 6 months, you may improve overall survival by 6 months at the expense of significant toxicity, mainly neurotoxicity. Large MRC trial which compared the standard MP to CTD attenuated, meaning cyclophosphamide, thalidomide, and dexamethasone at lower doses that usually used in patients of younger age. And in this trial, there was again a statistically significant but a clinically modest improvement in the outcome of the patients, with a higher rate of responses in favor of CTD. On the other hand, we know again for at least 10 years that the addition of bortezomib to melphalan prednisone, the VISTA trial, which compared it MPV to MP, was associated with improved response rate, was associated with improved PFS and overall survival, and a most recent publication with a long-term follow-up shown here indicated that there was a persistence of the improvement of overall survival in favor of MPV, and the benefit was in an excess of 1 year. Finally, earlier this year, we had the publication of the largest ever performed trial in myeloma, the first trial with more than 1,500 patients who were randomized in 3 groups. The standard group was MPT given for 18 months, and the 2 investigational arms included Len-Dex given for 18 months and Len-Dex given continuously. This trial showed that there was approximately a 30% reduction of disease progression or death in favor of continuous lenalidomide dexamethasone over MPT. The response also was improved in patients treated with lenalidomide and dexamethasone. You can see here that with Len-Dex, either for 18 months or continuously, there is a higher overall response rate and also a higher complete response and VGPR or better. The median time to response also was faster with lenalidomide dexamethasone of about 1 month, and also the duration of response was longer, especially in patients treated with lenalidomide and dexamethasone continuously. This curve shows the main endpoint of the trial, which was PFS, and as you can see from the green light, there is a significant improvement of the PFS in favor of continuous administration of lenalidomide and dexamethasone. Also, you can appreciate that the three curves are moving together until about the 18-month period, and this is the time where treatment was completed for MPT and for Lendex 18 months, and you can see the effect of continuous administration of lenalidomide dexamethasone being the major factor attributing to the improvement of PFS. So these data support the continuous administration of lenalidomide and dexamethasone as far as progression-free survival is concerned. This is the survival curve, and there is a small but statistically significant difference between the comparison of MPT, the white curve, and lenalidomide dexamethasone continuously, the green curve, in favor again of lenalidomide and low-dose dexamethasone. Because myeloma is a disease of the elderly, and we have an increasing number of patients over the age of 75, it is important to know what is the effect of any novel combination on patients who are older than the age of 75. And as you can see here, when the patients were stratified according to age, there was no real significant difference, indicating that lenalidomide and dexamethasone is a regimen that can be administered in older patients with myeloma and thus benefit these patients as well. Hematologic toxicity is shown here. To make a long story short, there was more hematologic toxicity with MPT. There was significant more neuropathy as expected with MPT. And overall, lenalidomide and low-dose dexamethasone was better tolerated. An unusual complication which we see now is the evolution of cataracts, indicating that with long-term administration of steroids, as you can see here in Lendex continuously, there are some side effects that will emerge that we did not used to see in the past. In this particular trial, patients with renal impairment were included, with the exception of patients who were on dialysis. So this trial resembled more than any prior trial to a real-life myeloma patients. And as you can see here, there is again an improvement of the outcome of patients with normal renal function or with renal impairment in favor of the administration of lenalidomide and low-dose dexamethasone. In this trial, lenalidomide dose was adjusted according to the creatinine clearance of the patients. So in the treatment of older patients with myeloma, we have one approach which is a fixed duration treatment, and usually these are regimens that include melphalan with a proteasome inhibitor, and also there are approaches of a continuous administration therapy. And I will summarize for you some of these trials. First of all, the first approach was with thalidomide, and as you can see here, in several of these trials there were an improvement of PFS, and in few of these trials there was an improvement of overall survival. The problem of thalidomide, as we know, is that it is unrealistic to believe that this is an agent that could be used for a continuous therapy because of the emergence of peripheral neuropathy. The other trial, which included a continuous approach with lenalidomide maintenance, was the 015 trial, which compared MP versus MP lenalidomide with lenalidomide maintenance and with an intermediate arm of MP with lenalidomide for 9 courses. Again, in this particular trial, the same pattern as we had with the first trial. The curves, they look together, they start to separate the moment that in one arm lenalidomide is continued and in the other arm it is discontinued. And also we had a more positive effect in patients 65 to 75 years of age, and in this particular subset of patients there was a trend for also improved survival. More recently, a HOVON trial was presented at ASH, which compared MPT with continuous thalidomide and MPR with continuous Revlimid, and the main endpoint of the trial was progression-free survival. So these are the data of the trial, and the main conclusions of the trial is that response was similar, with more than 80% objective response rate with either MPT with continuous thalidomide or MPR with continuous lenalidomide, and also PFS was the same. There was no real difference in the overall survival of the patients. These are the safety analyses, and as expected, in the MPT arm there was a higher rate of discontinuation due to neurotoxicity of thalidomide, and in the MPR-R the reason for discontinuation, which occurred in 25% of the patient, was primarily hematologic toxicity. Thus, with this trial, the conclusion is that the addition of lenalidomide to melphalan was not really improving the outcome versus the MPT trial. Another important trial which addressed the concept of continuous therapy was this trial reported by Antonio Palumbo. The control arm in this trial was VMP, given for 9 courses. The investigational arm was a 4-drug combination VMPT with bortezomib, thalidomide given continuously. Thus, not only we have a difference in the induction, but also we have a continuous approach versus a fixed approach. The most recent analysis of the trial is shown here. There was a PFS and an overall survival advantage in favor of continuous administration of bortezomib and thalidomide, and the overall survival advantage was seen primarily in patients 65 to 75 years of age. Whenever we administer these agents and these regimens at standard doses, we always see that the main advantage occurs in the age range of 65 to 75 years of age, and this, of course, is due to the better tolerance, the less comorbidities in this age group of patients. Now, let's move to some newer agents which have not yet been formally approved for the treatment of myeloma. And one interesting agent, especially in older patients with myeloma, for a continuous approach treatment is Ixazomib, an oral proteasome inhibitor, which can be given on a weekly basis. And usually, the phase 2 study showed that this is an agent which is well tolerated, and the primary study which has been reported so far in older patients with myeloma in the frontline setting is a combination of Ixazomib with lenalidomide dexamethasone given for a certain period of time, and then with Ixazomib given as a continuous therapy. The main take-home message from this slide is that with continuous administration of Ixazomib, you may see an improvement of response over time, indicating that this agent, given for continuous as a continuous approach, is able of improving the response rate, and thus most likely affecting PFS and probably the overall survival of the patient. So these are the curve along PFS in favoring the long-term administration of Ixazomib. Ixazomib has a favorable toxicity profile if one compares it to bortezomib. There is some peripheral neuropathy, but not really severe and not very frequent. Some patients may develop gastrointestinal toxicity in the form of nausea or diarrhea that usually can be treated with dose adjustment. There are some patients with skin toxicity, and some patients also may develop myelosuppression. Overall, it is an agent which is well tolerated, and it is really suitable for long-term administration. Other approaches is to incorporate two doublets like these two novel agents, like this VRD combination, which is being used extensively in the United States for younger patients with myeloma who are eligible for stem cell collection. So this is a modification of this RVD regimen with lower doses of both lenalidomide and bortezomib, the so-called RVD-like. This regimen is very active with a very high response rate, including many patients who achieved a complete response. Another novel agent which is showing significant activity in the treatment of myeloma is Carfilzomib. As you know, Carfilzomib has been approved in the United States for the treatment of patients with resistant relapsed multiple myeloma who have failed lenalidomide and eproteasome and bortezomib. Also, Carfilzomib has been evaluated in the relapsing setting, in the frontline setting, and also there are trials ongoing which evaluate the weekly method of administration of Carfilzomib. This is a phase 2 study from Antonio Palumbo, which used weekly Carfilzomib in combination with cyclophosphamide and dexamethasone. And you can see here that the MTD was a 70 milligram per meter square, and these are the response rate, a very high response rate with this combination, which administers weekly Carfilzomib with oral cyclophosphamide and dexamethasone. The safety profile is shown here. No signal to indicate that weekly Carfilzomib in this patient population may be more toxic than the standard or consecutive day administration of Carfilzomib. As expected, hematologic toxicity occurred in approximately 1/4 of the patient. Another important observation made the last few years in the treatment of elderly patients with myeloma is to formally show what we suspect and what we see in our everyday clinic, that not all patients who are over this age of 65 are the same. We frequently see very fit patients who are 75 or 80 years of age, and these patients may tolerate treatment at standard doses. However, there are frequent patients who have comorbidities from other organs. They take a lot of medications, they have coronary artery disease, lung problems, and these patients may be either unfit or sometimes even frail. And it is clear that these patients may require a different approach, and this was also formally shown by this large analysis of a database from the European Myeloma Network, patients treated in several frontline protocols, older patients with myeloma. And as you can see here, comorbidities are inducing higher toxicity, and drug discontinuation due to side effects is one of the major variables which is associated with an impaired overall survival. Thus, the tolerability of anti-myeloma therapy is an important issue, and this tolerability is usually reduced when the patient is unfit and even worse if it is frail. Thus, we need to use formal geriatric scales which assess comorbidity of the patients. There are several of those who have been developed for other conditions, such as the activity of daily living, the instrumental activity of daily living, and also the Charlson comorbidity score. By using these scales, the Italian group stratified their patients into fit, unfit, or frail, and used regimens which were adapted according to the dose, to the age, and to the condition of the patient. As you can see here, bortezomib is given weekly instead of twice a week. Melphalan is being given at reduced doses. The same applies for cyclophosphamide. Prednisone is being used instead of dexamethasone. Despite this adaptation, you can see again here that the outcome of patients who are fit, the yellow line, is better than patients who are unfit or frail, again indicating the individualized approach that one should follow when dealing with an older patient with myeloma. And this is some practical recommendations regarding the dose adjustment according to the condition of the patient. Dose level 0 is doses that could be used for an older patient who is fit, -1 for an unfit, and frail patients -2, and in some of these patients only palliative care may be appropriate. Thus, to conclude, today we have many treatment options for the older patient with myeloma who is not transplant eligible. We can choose between a fixed duration treatment and a continuous method of administration. It is not clear which approach is better. There are a subset of patients that clearly may benefit from a continuous therapy. There are other patients in whom a fixed duration treatment may be more appropriate with a treatment-free interval. And of course, modification, dose adjustment according to the condition of the patient is mandatory in order to give to these patients the best probability for response and also for long-term good prognosis. With that, I would like to thank you very much.
This excellent presentation.